Hi, this is your Nagraj, your nursing mentor, nursing guide. I welcome you all for the Karnataka Nursing Officer Academy, KNO classes. So in this class, we will be dealing with a very essential, very essential, very vital topic for all examinations. If you see all exams, like all your central government exams, state government exams, if you consider all exams, means there is no like people will not be having this without this topic. There is not be exam. Okay, if you see this topic, this is relating to like, it will be helpful for your examination also and your practical aspect also where you're working. If you're working in casualty, if you're working in a emergency department and all means it will be very very essential topic for you. You must know. You should must know. In last lesson only, if you see means we discussed about O2 devices, oxygen therapy, and airway series. So apart from that, I'll be dealing with all foundation and your nursing foundation topics. So coming to the today class, so we'll be dealing with basic life support. Okay, I will be splitting topic into three steps. Okay, three steps. First one is BLS and ACLS and choking management part. So without a delay, we'll start our today's sessions with a beautiful quote. If you see, believe you. Okay, you can half believe you can, and you are there halfway. Means first you are the person. You should believe in yourself. Okay, look into the mirror and say, "I will believe in myself." If you're believing in yourself, means you can do it. Okay, only the you. Okay, if you see in your family and all, only the your person can able to bring the changes in your family. So if you're thinking that you believe in yourself, you can halfway almost all it's done only. So believe in it. Okay, have a confidence. You can able to crack any exams of SN government and all. So coming to the today's session, that's your BLS. Okay, BLS is nothing but your basic life support. Okay, I'll keep in a very simple, very concise manner. Basic means very vital. Okay, very basic level at the ground level. Okay, we see at the basic level what we can do means only we can do hands-on compression. Okay, hands-on compression. Basic means very hands-on compression means non-medical or non like paramedics can enable to perform the BCLS. Okay, if some kind of training, some kind of skill hands-on training is there means the person can able to perform basic life support. First, I am going to deal with the terminologies. Okay, terminology relating to the BLS, ACLS, ATCN, and and PALS, and NALS, and ECLS. Okay, if you see the terminologies, so first terminology, if you see means topic only, it's that basic life support. Okay, basic life support. Okay, BLS. And if you see, okay, second one is your first one will be basic life support, and coming to second part, okay, second terminology, that is your ACLS. In exams and all, they're not going to ask you like expand ACLS, BCLS and all because it's all like non-considerable. But if you see, if you like get to know what is the expand and what is the full form of this topic means, this formula means you can able to like get the exam, okay, get the question easily. You can this will make you a question like it will increase your like MCQ reflex and all. If you like when you're applying your knowledge and when you see long term question and all, they will be writing a very short forms, BLS, ACLS and all. That time it will be helpful if you know the full form means. What is advanced? Okay, does anybody knows that? What is advanced cardiac cardiac life support? What it is? If you see, we escalated the life support from basics to advanced. Okay, we escalated the life support from basics to advanced. Okay, means we are including. Okay, we are escalating means something we are adding up. Okay, something we are adding to basics. That's called as advanced. So that what we are adding, okay, what we are adding extra masala. Okay, what we are adding extra salt means that is your medication. Okay, in ACLS, in ACLS will involve the medications. Okay, what kind of medications? We'll add the inotropics. Okay, means we'll add the cardiac contractility increasing drugs, and we'll add up some equipment. Okay, some equipment nothing but your defibrillator. Okay, we will add the defibrillator. Okay, shock nothing but your shock, and we will add the AED, because in a hospital or in a ambulance where there is a facility of such equipment means we can add up automated external defibrillator. This one also can be added. And if you see next, what we are adding, we're adding the O2 therapies. Okay, O2 by mask, O2 by NRBM, O2 by bag and mask ventilation. Okay, these things are added means we call that one as advanced cardiac life support. That is nothing but your ACLS. Okay, all of you clear that? Okay, moving to third terminologies, ATLS. Okay, ATLS. What does it stand for? Advanced. Okay, here also advanced. Okay, means something above the basic. Okay, advanced trauma. Okay, advanced trauma life support. Okay, advanced trauma life support. Okay, if you see what is the difference here? Okay, ACLS and ATCL or ATLS. Okay, ATLS, ACLS, we're considering on cardiac life support. Okay, only cardiac emergencies like cardiac arrest, heart, and your myocardial infarction. That is only where we are like focusing on. Here, if you see ATLS, trauma. Trauma nothing but something insult to your neuromuscular system. That is what we call as trauma. Okay, here we are involving the polytrauma, road traffic accident, long tissue injury, pneumothorax, cranial clot, and all that are all we are involving here. Okay, advanced trauma life support that indicate your trauma related. Okay, polytrauma related management aspect. If you see difference and all, ACLS we are following A ACLS we are following CAB. Okay, what is CAB? Circulation, airway, breathing. Means we are giving a priority to circulation. Okay, in ACLS. If you see ATLS, we are focusing on more mainly. Okay, we are targeting. Okay, we are focusing. We are figuring out on airway. Okay, that follows ABC criteria. Okay, ABC priorities. Okay, ACLS is follows CAB. Okay, ACLS CAB. Okay, ATCLS ATLS is follows. ATCLS follows. Okay, what it follows? Okay, it will follow A, B, C. Airway, breathing, circulation. Okay, that is a major difference if you see means. That's what your ATLS. In this class, we're not going to deal with the ATLS. Just I'll give a brief introduction about ACLS. And if you see PALS, what is PALS? Pediatric, advanced, life support. Okay, and one more term, NALS. NALS also called as NRP. What is NALS? NALS is nothing but neonate. Okay, neonatal advanced life support. And what is NRP? What is NRP? Neonatal resuscitation program or procedure. Okay, that is what your NRP. And if you see one more term is there, ECLS. What is ECLS? I think this one nobody is having like sensitivity towards ECLS. So I'm going to clear this topic. Okay, ECLS. ECLS means extracorporeal life support. Okay, extracorporeal means extra means away from the body. Okay, away from the life. Okay, away from the body. Extracorporeal means inside the body. Away from the body is extracorporeal means outside the body we are giving the life support. Okay, nothing but your cardiac and pulmonary function has been done by your machine. The machine name is ECMO. Okay, ECMO machine. Okay, heart lung machine. What we call as heart lung machine or ECMO machine. ECMO nothing but extracorporeal membrane oxygenator. Okay, it will oxygenate your blood and it will pump the blood. Okay, it will be having centrifugal pump will be there and oxygen membrane will be there. Okay, oxygen concentrator will be there. So your heart and mainly major vital organs are heart and lung. Okay, that both work has been done by your ECMO machine. Okay, that's what we call as you're putting patient on ECLS. Okay, when we'll go for ECLS, we'll go when this all BLS, ACLS, everything will fail means that time we're going to put the patient on ECLS, ECMO. Okay, that's what is your extracorporeal life support. And if you see, if you see, what is resuscitation? In if you see, means all doctors in EMS, in casualty and all, they'll be like frequently using the term called as resuscitation. Okay, resuscitation. What is that term? What is the meaning of the term? Means resuscitation. What is it means? Like basic term. Okay, basic term. It indicates of restoration of what we are restoring here. What we are restoring? We are restoring the life. Okay, that what is resuscitation means. We are restoring the life, or we are restoring the, or we are restoring the, what we are restoring? We are restoring the normal physiological function. Okay, normal physiological function of your heart and lung. Okay, your heart and lung, both function has been restored. Okay, what we call as ROSC means return of spontaneous circulation is called as resuscitation. Okay, if I'm using the term, okay, infrequent in classes means you should know that resuscitation means restoration of life. Okay, if we see, okay, this basic concept of clear means we'll move towards the topic. Okay, today's topic is basic life support. If we see, okay, what is the algorithms? Okay, what are the algorithm for starting BLS? Okay, when you're going to activate the BLS. Okay, if you see, I'll give one scenario. You're walking on a road. Okay, you're walking on a normal road, and the person is like walking in front of you. Okay, on suddenly he'll collapse out. Okay, in front of you, he'll collapse out, and you'll witness the situation. Okay, and you'll see the situation, and you're going to attend that person. Okay, you're going near to the patient. First, what you will see, just close your eyes and imagine and tell that a patient, like you're walking on a road and one person comes to you in front of you, and suddenly he'll falls down. So, what is your first response? Your first response will be safety. Okay, scene. Okay, look for the safety, because I told patient is walking on the road. Okay, walking on the road means there will be so many vehicles. Okay, road trafficking will be there. So you have to first see the safety. Okay, and one more scenario. If you see, means the person is a lineman and is working in a, okay, he's working on a pole, or else or something. Okay, something, you're walking on a road, some water is there, you just touch the water, some current may be there in the water, and the person is suddenly collapse out. So means electrocaution. Okay, electrical current shock. That situation, what you will do? First, you will see the safety. Okay, you will take the person from the source, away from the electrical source. And if it's on road, we given a situation called as on road only. First, we'll see the safety part. Okay. First, we'll take the patient from on center of the road to corner. Corner of the road or any safe place. We'll take the person to safe place. Okay, first, if we see a BLS algorithm, it starts from safety. Okay, safety is first. If you're starting anything means safety you should look after. Okay, if safety is clear, everything is clear. Not only like patient safety, you have to see for your safety also, because you are the rescuer. Okay, you should not get electric current, electric shock and all. So first you should see your safety also and patient safety also. If you are safe, then only you can able to rescue the other patient or other person. Okay, whoever we. After, okay, you confirm that the patient is on road, and you've taken the patient to a safer place. Okay, make sure that we must have flat surface. Okay, flat and hard surface must be there. After scene safety, what you will do? You will check the response of the patient, because there is like so many different cause of syncope, or else giddiness, or will be loss of consciousness will be there. So you should check for response of the victim. Okay, we are not calling here as patient because it is outside the hospital. We're calling him as victim. Okay, victim. After safety, what you'll go for? You will check the response. How are you going to check the response? Response check. How are you going to check the response? Okay, just think you're working in ICU. Okay, you will be checking the GCS for checking the consciousness level. Okay, what is GCS? Glossoscoma scale. Okay, in that we are having like three component: EVM, eye response, verbal response, and motor response. That is for check the patient level of consciousness we're going to use. But here, what I told, this is a basic life support. Means Jesus and all, nobody will study. Okay, they were non-medical professionals or paramedicals. They are not studying. They are not studying these years. So here, what we can do, we can check the response by shouting the name. Okay, not name like are you okay? Are you okay? We have to put a hand on the shoulder and we have to shake the person. Okay, are you okay? Are you okay? Like that, we can check the verbal response. Okay, through verbal stimulus, you can able to check. Or else, if verbal response fails, patient is not responding means you can go for painful response. Okay, you can check for give a painful stimulus. That may be your central painful stimulus, your sternal rub. Okay, you have to rub the sternum with your knuckles. Okay, knuckles are hard. Okay, you go to rub the sternum. Okay, you have to like give a painful stimulus over the sternum. That is your central painful stimulus. Okay, also you can tap on labella. Okay, that you can do. Also, you can pinch the pin of the ear. That all are central stimulus. If you want to check by peripheral stimulus, just if you're having a pen, anything stone is there means just put a pressure on a finger. Okay, now you checked a given painful stimulus, then there is no response. You given a verbal stimulus, are you okay? Are you okay? Patient is not responding. Okay, there is no response. Then your algorithm will move towards okay. A flow will comes down. Then what we will do? We will do assessment. Okay, we will do assessment part. What will assess? What will assess? Firstly, okay, our BLS stands for our BLS is having priority of cab. What priority we are having? Cab. Okay, we are having priority of cab. Cab is nothing but your circulation, airway, and breathing. Okay, last is your breathing. Cab. Okay, first in assessment part, what you're going to assess keenly means first you have to check the pulse. Okay, pulse is there or not. Which side you're going to check the pulse? If it is an adult, you're going to directly put a three fingers. Okay, three finger method. One is for volume, one is for rate, one is for rhythm. Okay, three finger method you should use. Just if it is an adult case, adult victim means just put a three finger hand. Okay, three fingers in your just locate first. You have to locate the tracheal groove. Okay, you're going to locate the tracheal groove. Side to the tracheal groove, you are having the carotid artery. Okay, in case of adults, we can go for carotid artery because it is an like a macro circulation. Okay, carotid artery is a macro vessel, so we'll get the early assessment. Okay, you can able to easily check the pulse. Okay, just we to check the see the tracheal groove. Side to that, you will be having a carotid artery. So okay, you assessed the now pulse. You want to assess. Okay, what is it? Three finger method. One volume, one for rate, one is for rhythm. Or else you just remember rate. Okay, we will check the pulse is there or not. Is palpable or not. That is only we needed here. Tracheal groove you located and you're putting three fingers in a tracheal groove. Okay, you'll feel for a pulse. Okay, if it is see that if it is adult, we're going to use the carotid. Okay, if it is an adult we're going to use carotid. Okay, carotid artery. If it is in case of if it is in case of okay child okay or pediatric case okay a child is a pediatric case is there means where we'll check we can check in a carotid. First priority will be carotid. Second priority will be your femoral pulse, femoral artery. Okay, if it is in case of pediatric and all. If in case of neonates, you should go for first priority will be brachial artery. Why? Why? Brachial, if you see in adults and all, it's very like very neglected artery. We not check the pulse in brachial and all. If you see, like we'll use radial or else tracheal, we'll use or else carotid will or else femoral. Why in neonates specifically we're going for brachial artery? If you see neonates, they're having like a very short neck will be there. In a very short neck and smooth the sternocleidomastoid muscle and your trachea will be very not that much calcified and not that much catalyst is there. So very difficult for assessment. Okay, first remember that very difficult to assess the carotid artery in case of neonates. So that time we'll use brachial artery. Okay, for neonates, brachial artery is easily palpable. Okay, you can easily palpate. So for assessing the pulse, okay, Assessing the pulse, how much time you should take? This may be your NORCET question. This may be probably your NORCET question. How much time duration should you should take for assessing the pulse? Okay, if you see means, if it is, it should be like less than, it should be 5 to 10 second. Okay, it will be 5 to 10 second. You should not cross more than 10 second. Why? If you're crossing more than 10 second, see, just you are now only you are starting, you are assessing the patient. You're taking more than 10 second means what will happen? Patient will go for hypoxic ischemic encephalopathy, anoxic injury will be there. So to prevent that one, you should quicken, okay, you should fasten your assessment. Okay, pulse should be checked within less than 10 seconds. Okay, maximum you should take 5 to 8 seconds, not more than 10 seconds, not more than 10 second. Okay, 5 to within 5 to 10 second we should finish the checking the pulse. I said pulse I told the site way to check the pulse. And if you see next assessment part, we're going to check the respiration. How are you going to check the respiration? Are you going to keep your fingers on your nose and check the you want to feel the breathe? No. Actually, before what it was there, no. To assess the respiration, we're going to use before like to if you see like 2010 guidelines of AHA, American Heart Association guidelines, they were giving guidelines of look, listen, feel, look, listen, and feel was there. What is that? Look, listen, feel. Look for chest upward, okay, chest rise and inward. Okay, during inspiration, chest will rise. During expiration, chest will fall. Means chest movement they wanted to look for chest rise and fall. Okay, and then listen to first you have to go near to the victim and you have to slightly bend your face towards the chest. First you should see simultaneously, look for chest rise and fall, and then you have to with the ear you have to feel for, okay, listen, feel, listen, okay, listen to breathe sound, okay, listen to breathe sound and feel for breathe air. Okay, that is what your respiratory assessment in like before 2010 guidelines of AHA. Okay, that is your look, listen, feel. Okay, look, listen, feel. But if you see now, we are like, because looking, listening, and feeling, it will take more than 20 seconds. So to reduce the time duration, what we are limiting respiration assessment, we'll see the patient from like two times. We'll see up and down. Okay, up and down. If you're seeing means you can able to see the chest rise and fall and all there means that we can see that through that one we can check the respiration. So you check now you check the respiration, now you check the pulse. So you're not feeling the pulse. Pulse is not palpable and respiration is not there. Okay, patient is not having respiration, or else patient is in gasping state. He is having agonal respiration. Means patient will be taking long deep breath and he'll be ceasing the breathing. That's what we call as agonal breathing. Okay, means so that is there. Okay, patient is impending of respiratory failure or pulse is not there. Okay, means patient completely unresponsive. So in assessment finding, what you'll feel, patient is non-responsive. That time what you're going to do, because you are outside the hospital, you are on the road. What you will do, you will call for the help, and you're going to activate the, what you're going to activate, you're going to activate the emergency medical response team. Okay, emergency medical response team, or nothing but ambulance. What you will tell, you are assessing the patient, you are busy with all these things. You have to point out one person standing over the, hey, blue shirt, just call the 108 or just activate the emergency medical response team. Just you have to give a command, you have to give the order for a specifically, you have to point out one person, you have to give the orders to that patient, and that person will be looking after activating your emergency medical response team. So after that, you won't wait, no, of course, because patient is collapsing over there, no pulse, no respiration. So until medical equipments, until medical facility will come, you will go for, you will activate the, you will activate what you will activate, you will activate, you're going to activate the high quality CPR. high quality, high quality CPR. Okay, activation of high quality CPR. I'm calling here as high quality. What is that high quality means? What that high quality defines? Normal CPR. I'm not calling this one as normal CPR. I'm calling high quality CPR. High quality CPR. If you see means what we're giving compression. Okay, we're giving the compression means we are pushing. Okay, we are compressing the heart in between the chest cavity. Okay, in between the ribs we are compressing the heart. Okay, manually. Okay, manually, externally we are compressing the heart. Okay, by giving external pressure. Okay, that's what your compression. Okay, compression. We compressing the heart in between the ribs. That is what your compression. I'm calling high quality. Quality what it is indicate. If you see BMW car, they'll be having like a good quality. Means if you see like reliability, functioning, and your like accurateness will be more. Here, if you're seeing here the quality of CPR, quality of compression, if you see means what do you call as high quality CPR, nothing but your compression rate. Okay, push hard, okay, push hard and push fast. Push hard, push fast. Okay, harder and faster. Your compression must be faster and harder. Faster means faster means how much? How much faster means 100 to 120 compressions per minute. Okay, per minute you're going to push the give a compression of 100 to 120. Okay, that much compression you should give within 1 minute. Push harder means depth. Okay, depth of the compression. Faster means rate. Okay, faster means rate. Harder means compression. Depth of compression should be okay. If you see adult depth of compression should be 2 to 2.5 inch. Nothing but 3 to 6 centimeter. See, this all are like 3-star questions. Maybe probably they'll be asking in exams and all. If you see that cab, I said ACLS follow cab, circulation, airway, breathing. That has been asked in your SGPGI exams. Okay, SGPGI exam 2024 exam. They asked a sequence of CPR, sequence of ACLS. They asked. Okay, means they given a ABC, a CAB. They given ABC like that. They given the options. That time you should know the sequelae of ACLS is your ACLS is circulation, airway, and breathing. If you see here, push harder and push faster. Okay, push harder and faster. Harder means rate. Rate means 100 to 120. How to keep the rate. Harder means depth. Okay, depth of the compression in adults 2 to 2.5 inch. Okay, means 3 to 6 inch. It should not cross more than 6 centimeter. Why should not cross more than 6 centimeter means if you see we are pushing the heart, okay, ribs too much, okay, too much deeper means more than 6 centimeter. What will happen? There will be chance of solid organ injury. There will be chance of pulmonary contusion. There will be chance of rib fracture. Okay, first organ injury during CPR is your solid organ injury during your CPR is your liver. Okay, liver is a solid organ, not lungs. Lungs are not solid. They are having air-filled cavity. So if you see liver, there is no cavity inside the liver. So that we call what we call as liver solid organ. Solid organs, your liver, spleen, all that are your solid organs. Okay, there is a chance of solid organ injury. That's why we have to keep the depth of compression must around 3 to 6 centimeter or 2 to 2.5 inches. If you see in case of neonates, in children same. Okay, in children's if you see means 1.8 to 2 inches. Okay, if you see in neonates 1.5 inch only we are going to limit. Okay, 1.5 only we have to give a compression. And if you see high quality is what? Quality means here we are giving accurate. Okay, we are having rate of faster rate of 100 to 120, 120 compression per minute, and hard depth must be 2 to 2.5 inch or else 3 to 6 centimeter. And if you see, compression must be without interruption. Without interruption means we are not interrupting here. In case of, okay, we want to change the rescuer. Okay, after 2 minutes, after 5 cycles, we're going to change the rescuer. Okay, who is giving compression will go for giving the ventilation. Who is giving for ventilation will come for compression. So that time, that's time also you should count. Okay, one and two and three. Then you have to give, okay, you have to hand over the compression to other person immediately. So there should not be any delay. There should not be any interruption. And if you see another characteristic of your high quality CPRs, that are your recoiling. We should give adequate timing for recoiling the heart. If you see, we are pressing the lungs, pressing the heart like that means there will not be a recoiling, there will not be a return of blood. If there is no blood, simply by compressing means there will not be a adequate cardiac output, there will not be adequate stroke volume. So we have to give adequate timing for recoiling the heart so that adequate venous flow will come, adequate blood flow will come. Then only you can give it to compress. Then only that will be an effective CPR. So these three are the this four are the different like qualities of your high quality CPR. Good CPR. What we call as good efficient CPR. Compression and without interruption, recoiling. These three you should focus on. So if you see rates, okay, if you see rates, compression ratios, okay, ratios. Compression raised to ventilation. Compression raised to ventilation in case of adult CPR, 30 raised to 2. Okay, means 30 compression in one cycle we're giving 30 compression and 2 ventilation. Okay, that is your compression and ventilation ratio. That is in case of adult one rescuer. One rescuer is means 30 raised to 2. In case of two rescuer, okay, two rescuer is there means same. Okay, same 30 raised to 2. It is in case of pediatrics, less than 14 year pediatrics. If only one rescuer, okay, one rescuer is there. One rescuer is means 30 raised to same 30 raised to 2 compression. Here, if you see here, two rescuer is means that will come down, okay, 15 raised to 2 because here there is more need of ventilation. If you see pediatric babies and all means they'll be having more respiratory rate, more O2 demand will be there, more O2 need will be there. So that we're focusing on ventilation part here. If two rescuers are available, means focus on ventilation, not on too much on compression. So if you see neonens, this will differs, okay, from 3 raised to 1, 30 compression and 1 ventilation for neonens. If you thorough with this topic, okay, if you thorough with the ratio, definitely I'm sure that this is going to give you 4 marks in your exam. Okay, one correct answer will give you 4 marks. See, just think that, okay, if a paper is very difficult, it will be difficult for everyone, no? So that's not going to decide your rank. The thing that everyone are making this question right. If you are doing wrong in that means that is going to take your rank down and it's going to like prevent your selection. It's going to obstruct your selection. So to prevent that one, you should like remember these ratios. One rescuer is means how much ratio we have to give. Two rescuer is how much we have to give compression and ventilation ratio and all. Adult, one rescuer, two rescuer. So there will not be any change. 30 raised to fixed in mind that adult means only 30 raised to 2 we have to give ratio. Pediatric it will change. One rescuer is means you will go for 30 raised to 2 compression and ventilation ratio. 2 respiratory means will increase. Okay, will decrease the compression, will increase the ventilation part. We'll focus on ventilation. So 15 ratio 2. In case of neonates, will be 3 ratio 1 only. It will remain same. So that is what about your compression. Nothing but your high quality CPR. Okay, CPR. CPR. Didn't get cardiopulmonary. Okay, pulmonary means lungs. Okay, lungs is nothing but your airway. So if you see a ventilation part, so we are starting CPR. Okay, we given a compression. We are given a high quality compressions. Nothing but push hard and push faster. Okay, 100 compression we are keeping up, and two ventilation and we are pushing up to 2-inch depth. Okay, if you see ventilation part, respiration. We are dealing with the BLS. Okay, BLS. If you see respiration part. Here we are not having any devices. Okay, any bag and mask ventilation is not there. Okay, and first what do we have to do? We can have a hand pocket mask, or else mouth to mouth we can breathe, we can give. If you see like mouth to mouth breathing now, first we have to open the airway. Okay, in respiration part we have to open the airway. How we going to open the airway? Open the airway. There are open airway opening techniques are there. Okay, airway opening techniques are there. One is your chin lift and head tilt. Means chin. Okay, this mandible you are lifting, chin lift and head tilt. That's what your head tilt and chin lift maneuver. Through that we can open the mouth, open the airway. And one more, if any jaw spine or any C spine injury is there, any cervical spondylitis is there, means that time we cannot give a head lift and chin lift, because it's going to narrow down your C spine angle, so that it's going to further cause a injury to your C spine. So in that case, we're going to go for jaw thrust maneuver to open the airway. Here, nothing we are doing. Just with the two finger, we are putting a two finger into your temporomandible joint and we are lifting the mandible to 30 degrees. So this is a different technique to open airway. So now we open the airway. What you will do? Open the airway. Then you are going to pinch the nose. Okay, pinch the nose and pinch the nose, open the mouth, and give a mouth to mouth breathing. Okay, mouth to mouth breathing. Okay, mouth to mouth. Here you have to pinch the nose, open the mouth, and then give a breathing. If you see, we'll take a before giving breathe, we'll take a deep inhalation. Okay, deep inspiration, and after that you hold and open the mouth, pinch the nose, and give a forceful exhalation. If you see exhalation, will if you see only inspiration will be having 21% O2. Percentage O2 during inspiration will be there. If you say expiration will having very less amount of O2. So that is also will be helpful for patient. 16% O2 will be there during expiration. So that is going to ultimately help the patient. Room air will be having 20% O2. Okay, if in expired air will be having 16% of O2 oxygen will be there. So that we can do. If after medical emergency team arrives, that time we can go for. Now we are having the bag and mask ventilation. Now we are having bag and mask, nothing but your ambu. What is ambu? It's not ambu, it is ambu. Okay, ambu. What is ambu? Artificial. I think so many people will be using ambu, but they'll not be knowing the expanded expanded term for ambu. Artificial manual breathing unit. It will be having capacity of 750 ml. Adult ambu basically means will be having a ambu, nothing but artificial manual breathing unit. Okay, breathing unit. This is also called as self-inflating bag. Self-inflating bag, or else bag mask ventilation, BMV. All these are terms used for BMV. Okay, if you see a bag and mask ventilation, the person is like who is attending, who is rescuing the patient. One person will be busy with giving a compression. If you see, oh, this part I missed it. No, how like while giving CPR, no, while giving CPR compression, how you should compress the chest. Compression, if you see, means we must, okay, if you see here, you should use the heel, okay, heel of the palm. Okay, you're using the heel of the palm, and that is your non-dominant hand. Okay, that should be your non-dominant hand. Heel you should use, and but the dominant hand over the non-dominant hand, the finger should be interlocking. Okay, finger should be interlocking, and the elbow should be straight. Okay, elbow should be straight. Okay, we see my elbow is very straight, and I will be leaning on the patient. Okay, leaning on the victim means I'm using the shoulder pressure. Okay, shoulder pressure I'm putting out on the patient, and I'm using the shoulder pressure. I'm giving the forceful. Okay, harder compression. One and two and three. We should say and, because to give the recoiling space for the heart, so that that will be completely stored in heart, and that can be compressed. So compression must be in high quality high quality compression. We should include, we should use the heel of the palm. Okay, heel of the palm, and 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 we should interlock the fingers. Interlock the fingers. And one more thing, we should use the shoulder pressure. Nothing but your body pressure we should use. Okay, shoulder pressure we should use. That we can include in your compression part. Okay, if we coming to respiration, and we are going to deal, we're going to now ambulance has been arrived. We got the O2 device, oxygen bag and mask, ambu bag with the reservoir. We connect to O2. Then one person is stabilizing, is taking over the ventilation part, and another person is taking over the compression. So there is a two technique to use, hold the bag and mask, ambu bag. So E and C technique. E and C technique means like that we have to hold and we have to lift the jaw and we have to give the breaths. So how much we will give? How much will we have to like inflate? We have to compress the bag. Okay, compress the bag. Two-third part. Two-third part we have to compress. Two-third compression we should be given in ambu, and every 5 seconds one breath should be given. Okay, you have to count while giving breath. You have to count one and two, one, two, three, four, five, one breath. And again one, two, three, four, five, one breath given. So that 1 minute, a patient will get the up to 10 breaths will get. So here our main focus is on compression. So if this all are the like basic airway management thing, but your basic respiration management. And if you're having like a OPA, oropharyngeal airway, NPA, we can able to insert that one, and we can able to ventilate the patient. So this is the respiration part. Oh, so now we're coming to that algorithm of respiration. First we see the scene safety. After we check the response. In response, no, we can check the response by AVPU score also. AVPU. Okay, response checking can be done by AVPU. What is AVPU? What is AVPU? Response checking by response can be checked by AVPU score. What is AUPU? Use it in case of emergency when you are not having time. We'll use a because JCS will be taking assessing the JCS will take time. Mainly in neuro case, in ICU patient, we'll going to use a JCS, not in emergency. Emergency, are going to use AVPU score. A nothing but alert. B nothing but verbal response. P nothing but painful stimulus. Painful stimulus. U nothing but unresponsive. So that is what your AVPU score: alert, verbal response, painful response, and unresponsiveness. So this all your now we're going to like continue First, we seen the same safety. After that, we check the response. Now patient is unresponsive. Now we'll go for assessment part. We'll assess the cap. Okay, circulation. Circulation we assessed. Okay, so assessed means carotid pulse is not there, brachial pulse is not there, femoral pulse is not there. We taken a less time. Okay, less than 10 seconds we taken the time and we saw respiration. Okay, respiration is not there. Patient lungs is not expanding and relaxing. There is no just rise and fall. So next we'll do what we'll do. Next we'll do we'll activate the high quality CPR. Okay, nothing but your high quality compressions. Compression must be harder, faster. Okay, rate must be 100 to 120 rates per minute. Okay, and after that we focused on respiration. Okay, airway we you open the airway by techniques head tilt and chin lift, and after that jaw thrust also we both manuals we use it to open the airway. We open the airway, after that we pinch the nose and open the mouth and given the mouth to mouth breathe. After that, we got the ambu bag and O2. Then we connected the ambu with the E and C technique, and we giving the ventilation per every 1 second, one breath we are giving. Okay. After that, we focus on breathing also, airway, breathing over. Now this completes your airway, breathing. Sorry, circulation, airway, breathing. Why we focus on circulation means because already in heart some amount of blood is there. First, we'll try to compress the blood. First, we'll give that blood to all your vital organs, brain, lungs, and all will give. After that, we'll see on breathing part. So that's why in ACLS they added circulation is your highest priority. Nothing but your compression. You should start from compression. Okay, that's what your algorithm of ALS. Okay, you started high quality CPR. After that, what you have to do? No, you have to check the reassess the patient. Reassessment. Sorry. Sorry, before reassessment, no. I said now ambulance has been came. Ambulance has been came. It is having like some equipment called as AEDZ. Okay, AED is also available. What is AED? Automated. Automated. AED is nothing but automated external external defibrillator. So it will be having like two pads will be there on machine. On machine will be there. It will be giving you commands. Means automated. It's automated. It's going to sense and it's going to give the commands to you. Okay, orders to you to what to follow. The pads you should attach one pad. Okay, pads attachment. I'm telling AED pad attachment. First one pad should be attached below the clavicle. Okay, 1 centimeter below the clavicle you should apply. Second pad, sixth intercostal space. Intercostal space. Okay, here just exactly sixth intercostal space. Okay, mid clavicular, imaginary mid clavicular line. Mid clavicular line. We should attach the second pad. See, just right side, right pad you should keep below the clavicle. Okay, 1 centimeter below the clavicle you should attach. Next pad you should keep on the sixth intercostal space. And if you see like clavicle is here, some center of the clavicle I will put on imaginary line and I'll point out the sixth intercostal space. There I'll keep a one more pad. So there you given you attach a pad and you stop for a while giving CPR, and the machine will you start on the AED machine and it will give the commands. Okay, what it will give? It will give two commands mainly. Okay, shockable rhythm. It will say shockable rhythm, and it will show non-shockable rhythm. Non non-shockable rhythm. If you see the term defibrillation, what is fibrillation? Fibrillation means it's fibrillating. Okay, it is dancing. It's not compressing. Normal heart, how it will be? It will be contracting. So if contraction is not there, it's only fibrillating. So that time, what are you going to do? We're going to stop that fibrillation. That's what we call as defibrillation. We're going to give a shock and that dancing will stop. Then after that, it start the contraction. So in case of fibrillation, okay, ventricular fibrillation, okay, that time only we're going to use the defibrillator. Nothing but we're giving the shock. Okay, whatever your shockable rhythm is your VF. Okay, ventricular fibrillation or pulseless pulseless ventricular tachycardia. We want to use the that is what your shockable rhythm. Non-shockable rhythm will be asystole, means flat line. Okay, flat ECG. That is what your asystole, or else PEA. Nothing but your pulseless electrical activity. Here there is no fibrillation. So that's why we're not going to use the shock. We're not going to use the shock device. So if you after attaching pads, the AED machine automatically it will give a command that it is shockable rhythm. If it is shockable rhythm, what will do? You will give the button charge button on. Okay, if it is charge button on means automatically it will deliver the current. How much? 120 joules. In case of monophasic, oh sorry, it is biphasic. In case of biphasic, it will be deliver the 120 joules. If it is non-shockable, what you have to do? You have to resume. If it is non-shockable, asystole means you should resume the CPR. Even here also, after delivering one shock, you should stop the AED and you can again immediately resume the CPR, because heart is fibrillating. Okay, it's not contracting, it's fibrillating. Then you give the shock, then heart will be stopping. Okay, heart will stop contracting, stop dancing. So that time you have to compress the heart so that heart will get compressed. Okay, it will give start contraction. So you have to immediately after delivering the shock, you should resume the CPR. Okay, that's what about your AED, automated external defibrillator. Okay, after that, okay, this all everything done. Airway management, breathing management, circulation, compression, everything you given, and you're having the this one AED machine also connected AED machine, shockable, then non-shockable, everything you've done. After that, what you will do? You will reassess the patient. After how much time should take? This all intervention, this some compression, ventilation, AED, everything should finish within 2 minutes. Up to 2 minutes, or else 5 cycle of CPR. You should reassess the pulse and respiration. You should assess. Okay, pulse and respiration you assess it. Now you're feeling for carotid artery. Now you will feel the pulse present. Pulse plus respiration present. Then what you will do? Now this condition is called as ROSC. What is ROSC? Return of spontaneous return of spontaneous circulation. What is ROSC? Return of spontaneous circulation. Okay, if that is achieved, okay, just we'll shift the patient. We'll that this time will not do anything. We'll keep that patient and we'll shift the patient to hospital. Nearby hospital will be shifting out. In hospital, they're going to see the patient. They're going to go for advanced advanced airway management. Means they're going to intubate the patient. They're going to tracheostomize the patient, and after that, they're going to correct the reversible cause of arrest. They're going to correct. They're going to treat the reversible cause of arrest. What are reversible cause of arrest? See, I said arrest. What is heart cardiac arrest? Cardiac arrest is, I think we dealt. Okay, 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 okay. What is cardiac arrest? Arrest means something arresting. Okay, cessation of electrical activity of the heart is called as cardiac arrest. Means we arrested. Okay, arrested the heart. How we arrested? Electrical activity has been arrested. Means there is no pacemaker SA node activation. There is no electrical excitability. So that's what we call as electrical cardiac arrest. Means there is no conduction. Okay, failure of conduction. If you see a heart attack, something is attacking the heart. Okay, heart attack means something is attacking. What is attacking? What is attacking? There is a thrombus. Okay, there is thrombus which is blocking. Okay, it's blocking the coronary artery. Is called as heart attack. Then what is heart failure? See here you are not feeling because you are having confident because you are confident enough. So that's why your heart is not fully feeling like that. But here if you see means heart failure. What is failing your? What is failing here? Failure of the heart. What is normal function of heart? Pumping action. So failure of the heart to pump the blood. I'm keeping the simple sentence. Okay, keeping it very simple definitions. Failure of the heart to pump the blood is called as heart failure. So we are activating the cardiac AC BLS in case of all this condition: heart attack, heart failure, cardiac arrest. That time we're activating the we're activating the ACLS or the BLS. So if you see all these things, what I said, we achieved the return of spontaneous circulation. ROS we achieved after that we shifted the patient. What they will do in hospital, they're going to stabilize the airway, okay, by intubating the patient, by keeping the patient on ventilator, and then what I told, they're going to correct the reversible cause of the arrest. Okay, what is the reversible causes of arrest? What are reversible causes of arrest, cardiac arrest? There is a mnemonic 5H and 5T. Okay, 5H and 5T are the reversible reversible cause of cardiac arrest. Okay, what are the 5H? First H, second H, 3, 4, 5. Okay, what is first? First H is for stand for hypothermia. Patient may be case of drowning. Patient may be a case of cold stroke. So that is your first H. Okay, hypothermia. Next is hypovolemia. In hospital there will be facilities of there will be facility of your warmer blanket and all, so you will correct the hypothermia first and then hypovolemia. In hospital how they going to correct the hypovolemia? By giving the crystalloids and plus colloids. They give you albumin, they'll give the hemigel. It's all they're going to use, okay, to correct the hypovolemia. They correct the hypovolemia. Now if you see third H of your reversible cause, that is your hypoxia. Okay, what is hypoxia? Hypoxia nothing but less oxygen. Okay, oxygen is less in your blood vessel, in your blood. Okay, there is a hypoxia. Hypoxia nothing but less concentration of O2 in your blood. That's what we call as that is hypoxemia. Less oxygen in tissue is called as hypoxia. So patient is not ventilating properly. So that patient will be kept on ventilator with the high effort to requirement. So in hospital, they want to treat the hypoxia by giving hyperbaric oxygen. Okay, increased concentration of oxygen they're going to give. And if you see third H, hypo hypokalemia. Okay, hypokalemia. This can be treated, okay, by giving the KCl injection. And hyperkalemia. Hyperkalemia. We can add up hyperkalemia and hypokalemia here only. Okay, hyper and hypokalemia, because hyperkalemia will cause diastolic arrest. So hyperkalemia can be treated medically by giving neb-salbutamol. Neb-salbutamol you can give, or else insulin you can give. Okay, 10 units insulin in 25D. So to prevent hypoglycemia also we can give a insulin. Okay, 10 units insulin we can give. Again we can correct the hyperkalemia. And if you see one more H, that is your hypoglycemia. So soon after reaching the hospital, they're going to check the glucose random blood sugar GRBS. If it is less than 80, they're going to give 25 percentage dextrose. So these are the 5H of reversible cause of cardiac arrest. Okay, hypothermia, hypovolemia, hypoxia, hypo or hyperkalemia. Nothing but your potassium plus or minus. Okay, plus or minus potassium, and hypoglycemia. So this all are the reversible cause of cardiac arrest. And if you see 5 T's, okay, 5 T's. What are your 5 T's? First T will be tension pneumothorax. Tension pneumothorax means there is an refracture, or there is an rupture of your bulla. It will cause a tension pneumothorax. Means tension. Pneumo means lungs. There's an compression of lungs. Okay, by the air in a pleura. Okay, pleural air is going to compress the lung, so that ventilation is not happening properly. So that may be causing the patient a cardiac arrest. So to prevent that one, in hospital they're going to do a needle decompression. What they will do? They will take a large bore needle. They will put a needle in a second intercostal space, and they're going to insert the needle, and they're going to remove the needle decompression. They can do with a large bore needle, or else they can put a ICD if it is in too much facilities are available. Means they can go for ICD placement also. And next, tamponade. What is tamponade? More than 200 ml blood is collected. Blood is collected in your pericardial space is called as tamponade. What is dextride? Muffled heart sound. Muffled heart sound. Raised JUP. That's what's the component of your dextride. Okay. Pericardial space is called as cardiac tamponade. Means heart is it's having layers. Okay. Endocardium, myocardium, and pericardium. So, okay. If there is a space between the pericardium and myocardium, that's what we call as pericardial space. There is normally some 50 ml of fluid will be there. So it is that is like more than 200 mils, that what we call as tamponade. So it is compressing the heart to contract. So this comes under the category of restrictive cardiomyopathy. Okay. So there will be less stroke volume, there will be less cardiac output. So there will be less of the patient may go for arrest. So that time, what we are going to do? We're going to do a, what we're going to do? We're going to perform a needle decompression only here. We're going to put the needle inside the 6 inch space. We're going to drain out the extra amount of blood. So that's all. What about your 1 minute? Sorry for the delay. And if you say next T, toxins. Okay, in case of OP poisoning, in case of paraquat poisoning and all, toxin can be removed. Okay, toxin can be removed and by dialysis. If it is hospital facilities are there means. And the next if we see means trauma and Net 2 minutes. Sorry for the interruption. Subcharging. So if you see toxins can be removed by a dialysis. Okay, toxins can be removed by dialysis. So in hospital facilities are available, so we can go for dialysis and we can safeguard the patient. And next, if you see means thrombosis. Okay, thrombosis means thrombosis is in pulmonary tree. Okay, where pulmonary vessels is having any thrombus. If patient is having any DVT, that's going to dislodge and going into pulmonary tree, pulmonary artery and all. It's going to occlude the all like pulmonary circulation. So there will not be a adequate ventilation perfusion. So that is going to be too much fatal for the patient. If patient is coming in a window period means we can thrombolize the patient. We can thrombolize the patient by giving STK, streptokinase, urokinase. These all are the these all are the TPA inhibitors. Okay, tissue plasminogen inhibitors. Sorry, activators. TPA activators. Tissue plasmin is going to clear the plasmin is going to cut the thrombus. And one more thrombus, fifth thrombus is in your coronary artery. Nothing but your MI. So this can be treated by doing the angioplasty. Okay, coronary CABG, coronary artery bypass graft also we can do, and also we can do PTCA. Okay, percutaneous transluminal angioplasty also we can do. So if it's patient is reaching the hospital facility means we can do all this one. So that comes in. This comes in the category of post post cardiac arrest care. Okay, post cardiac arrest patient came to hospital. They manage the airway with intubation. They want to treat the reversible cause and all. That comes in category of post cardiac arrest care.